Hey everyone, so similar to previous modules, we are going to be covering two different systems this week. We're covering spleen, and then we will also be talking about the lymphatic system, which is part of our immune system. The spleen and the lymphatic system are pretty closely related to each other because the spleen is considered part of the lymphatic system. So we'll learn a little bit more about the physiology aspect of lymphatic organs once we get into that lecture. But we're going to start with our splenic pathology first, and we're going to talk about some variants to begin with. The spleen does have a few variants that are very common to occur. And basically these variants happen in utero, right, when we're a developing embryo, and some type of abnormal progression has occurred to result in one of these variants. So one of the first ones that we are going to be able to actually address on ultrasound is wandering spleen. And this is basically when the spleen is located in any position outside of its normal left upper quadrant location. So if you are scanning that left flank, that left upper quadrant, you're jumping rib spaces, you're looking anterior, posterior, you're rolling your patient, and you still can't find it next to that left kidney and next to that diaphragm on the left side, chances are it's a wandering spleen. So it's going to be located somewhere other than that typical location. So this happens when we have the abnormal migration during the developmental stages of embryology, and basically the majority of our abdominal organs develop in the pelvis of an embryo, and as we grow in utero, they start to migrate upward, right? We remember that from our kidneys. The spleen is very similar to that. So it kind of gets stuck somewhere in that transition from the pelvis up to that left upper quadrant. So we want to be looking in that region. We want to be scanning down into the pelvis, looking in the inguinal canal to see if that's where our spleen is located, or even looking a little bit more midline towards the pancreas, or a little bit more superior, closer to that diaphragm. Clinically, the patient's going to be asymptomatic. They may have some tenderness in the region of where that spleen is located. Again, this is outside of the left upper quadrant, and torsion is possible. So we have this organ, this crescent-shaped organ that should be sitting in a nice little nook in our left upper quadrant, and it's not. So if it's in a position or in a location where it's very easy for it to turn on itself, it can result in that torsion. On ultrasound, we could see it as an abdominal or a pelvic mass, right? If we see a echogenic solid mass of tissue in the pelvis, our first thought isn't to think of a wandering spleen, right? We're thinking of some adnexal mass or some type of pelvic mass, when in reality, it's just the spleen that hasn't migrated up to its normal position. We also can see decrease in color Doppler velocity, or evaluation rather, in cases of that complete torsion. So when we put our color on, we're not getting as much color. When we Doppler it, we're not getting as strong of a signal, and that's going to indicate to us that there could be some type of torsion happening on those vessels. And then as for this picture here, we can see that our spleen is sitting right next to our bladder and our uterus. So that would definitely be a pelvic location for that wandering spleen. Next, we have splenic agenesis. This is also known as asplenia. Anytime we see A, that means that something is missing. This is the complete embryologic absence of the spleen, so the spleen has never developed in this patient. This is a benign finding, but we do see this in conjunction with other pretty severe congenital abnormalities. So when we get into OB, we're going to learn a lot about chromosomal abnormalities, congenital abnormalities, and you'll learn that when we see something wrong in utero with an embryo or a baby, they're usually not isolated findings. So that means that when there's some type of congenital abnormality, that there are several things wrong in terms of the development of that baby. So splenic agenesis, although this in and of itself is a benign condition, it is something that we're seeing with much more serious complications and other conditions. This is rare, so we're not seeing splenic agenesis too often, especially if we're not seeing it in conjunction with a congenital abnormality. Clinically, these patients are at an increased risk for infectious disease. So as we just said, the spleen is part of our lymphatic system, and that's generally our immune system. So if we're missing the largest organ in that lymphatic system, then chances are we're not going to be able to keep ourselves as healthy as we would like. So we're going to be at a higher risk of contracting and having worse symptoms from an infectious disease. On ultrasound, we are not going to be able to evaluate any splenic tissue. So this is where we want to make sure that we are not, we're not just saying that there is splenic agenesis in a patient when really they have a wandering spleen that's located in the pelvis, right? So we really want to make sure that we're evaluating every compartment of that patient's abdomen and pelvis to find anything that can resemble splenic tissue. Next, we have our accessory spleen. So this is something that you have probably all seen in clinical, and maybe some of you have seen in lab on your partner. This is also known as a splenule. So these are these little collections of normal splenic tissue that are separate but near the spleen itself. This is a very common congenital anomaly. It affects about 30% of the population, but there's nothing really crazy associated with these. They're typically going to be 1 centimeter in size or less. We're not really seeing these really large splenules. They're all going to be give or take around 1 centimeter. Clinically, the patient will be asymptomatic, but they may have a palpable lump depending on the location of where it is. So usually they're going to be located near the hilum. So that's what this picture is showing, right in that hilum of the spleen. But sometimes if you're evaluating the tip of the spleen here, you'll see one right up at that superior border, and that's going to be more likely that the patient can feel it when it's located a little bit closer to their ribs. And because those are actual splenic tissue, they are going to represent the same level of echogenicity. So the splenules are going to be isoechoic to the spleen itself. Next, we have splenic atrophy. So this is also known as autosplenectomy. Now, anytime we hear an ectomy, we think of a surgical procedure where we remove something, but that's actually not the case with this. So autosplenectomy, this means that the spleen is kind of removing itself. So it's shrinking. This is going to be a decrease in that splenic tissue volume, technically a benign disorder, but it's also going to be associated with wasting diseases. Wasting diseases are any disease that has a really severe impact on that overall metabolic state of the patient. They drop massive amounts of weight. They are very weak, and overall they are quote unquote wasting away. So we're seeing splenic atrophy in those conditions and diseases. Clinically, the patient will be asymptomatic, or they're going to have symptoms that are associated with the disease that is causing this atrophy. So if they have some type of we could even say leukemia, right? So they have some type of blood cancer that's a wasting disease over a period of time that patient is fighting that disease, and that disease is attacking the body. That spleen is just going to continue to shrink and shrink and shrink. So it's a benign thing that happens on its own, but it's also going to be associated with more severe conditions. On ultrasound, we are going to see a very small spleen, so less than 8 centimeters in length, or we could see non-visualization of any tissue due to an extreme case of atrophy. So it can actually atrophy so far to the point where we're not able to evaluate any splenic tissue. And again, that can be where we confuse it with asplenia, right? So we want to be aware of that patient history. Next, we have our splenomegaly, so the exact opposite of splenic atrophy. This is the enlargement of the spleen. This is going to be caused by some type of systemic disease. Mono is usually a very big culprit of splenomegaly, so we see this a lot in teenagers. Teenagers are more prone to get mono. Clinically, we're going to see this in a patient who is undergoing some type of infectious process, or they have a metabolic disorder or a blood disorder that's causing that spleen to be reactive and enlarged. On ultrasound, of course, we're going to see a spleen that is measuring very large, so greater than 12 centimeters in length. We're going to see an increase in volume. So really all 3 of our measurements are going to be larger than they should be. And we can see some changes in texture and vascularity, but for the most part, that spleen is still going to be its normal architecture. So this bottom picture, well, really the top picture, we can see that the length of this spleen, that SAG measurement, is 20 centimeters. That is a massive spleen, right? And if we look at that bottom picture, we have our spleen touching our liver. So that spleen is so enlarged that it's coming across the anterior aspect of the patient towards the right side of that patient's body. And that's how big it is and how much space it's occupying. Next, we're moving into our physiologic processes. So some conditions and diseases that are pretty isolated to the spleen. Our first one is amyloidosis. 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 I will never expect you guys to be able to pronounce a lot of these conditions accurately. And every time I think I know how to pronounce a condition, I hear someone pronouncing it a different way. And I'm going, oh my gosh, is that actually the right way to pronounce it? So what this is the excessive production of amyloid proteins in organs. So our spleen is actually going to be the most commonly affected organ from this. It's going to be very sensitive to that type of protein. And we're going to have like these little pockets of these protein accumulations. So think of like fatty liver, right? We have those excessive fatty triglycerides being deposited in that hepatocellular space. This is going to be similar to that, but instead of those fatty cells, we're now talking about amyloid proteins kind of just accumulating in that splenic space. So clinically, this is a systemic disease, and we can see this with other systemic diseases. Patient is going to be fatigued, have overall general weakness, joint pain, weight loss, skin changes. On ultrasound, we're going to see a potentially enlarged spleen. But anytime we have a chronic physiologic process, over a period of time, the spleen can become atrophied and a little bit irregular. And then the size of the spleen itself is really going to depend on the amount of this protein buildup. So if we have a ton of protein buildup, well, of course, that's going to make the spleen larger and larger, right? So initially, with a lot of production and storage of this protein in the spleen, we're going to see a very enlarged spleen itself. But over a period of time, that spleen is not going to be able to function properly. So we're going to see it start to become shriveled and a little bit more nodular. So all of these hyperechoic little regions are all the areas of that protein buildup. It's very heterogeneous because of that. Next, we have Gaucher's disease. This is a rare metabolic disorder where we have the abnormal accumulation of lipid cells in specific organs. So we can actually get Gaucher's disease that affects, a variety of organs. Our organs use lipid cells, right? It's not something that is isolated to just one organ. All of our organs utilize lipid cells in some sense or another. So Gaucher's disease can occur pretty much anywhere in the body, but the liver and the spleen are going to be the most commonly affected organs by this, and we're pretty much going to see it isolated to that spleen and that liver. Clinically, it can affect patients of all ages, but this is typically something that's going to occur in younger patients. So the majority of cases are going to occur in pediatric patients, so under 8 years old, and then a good amount also occurring under the age of 1. So this is not something that, a lifestyle diet is going to really affect. This is just a rare disorder in terms of metabolism for these patients. On ultrasound, we're going to see an enlarged spleen, a heterogeneous spleen because of that accumulation of those lipid cells. We could potentially see multiple hyperechoic nodules, again, kind of similar to the amyloidosis, where we're evaluating those actual pockets of where there's an accumulation of a certain type of cell. Next, we have Niemann-Pick disease, another metabolic disorder. This is where we're unable to break down lipid cells. So unlike Gaucher's disease, where we have the accumulation of those lipid cells, now our body actually can't break down those lipid cells. So the cells are going to start to malfunction, and it's going to lead to cellular death, apoptosis. That's a very big biology term that you probably remember. Clinically, this is common in female babies. It rapidly progresses because if our body is unable to break down fat cells and lipid cells, unfortunately, our organs are, going to malfunction and then potentially lead to organ failure and cellular death. So it can progress to become a fatal condition. On ultrasound, we're going to see hepatomegaly, we could see lymphadenopathy, we're going to have digestive complications. And basically, the reason why we kind of pool this in with our splenic physiologic processes is because our spleen is responsible for breaking down a lot of those lipid cells. Yes, it is a lymphatic organ, but it does serve other purposes of metabolization and filtering our cellular components through the spleen. So clearly with Niemann-Pick disease, if we're unable to metabolize our lipids, our spleen isn't working properly. So it's kind of like a second-hand condition in relationship to the spleen itself. Next, we're going to talk about some blood processes. So we just said that our spleen is a very big kind of gateway in terms of synthesizing all of our different cellular components. So it's responsible for filtering and synthesizing. It's also responsible for production of a lot of things, white blood cells, red blood cells. So the spleen is kind of a variety in terms of its actual purpose and function. So when we have blood conditions or abnormalities with our blood, we want to be able to look at that spleen and evaluate if that's where it's originating. So sickle cell anemia, this is something that you've probably all heard of before. It's when our red blood cells are no longer like nice and round and circular. They become very irregular shape. And when those cells are no longer nice and round and circular and donut shaped, it makes it harder for them to travel through our vessels. So we basically have an overwhelming amount of poorly shaped red blood cells. We don't have enough normal, healthy shaped red blood cells. So basically our organs are not getting the appropriate amount of blood supply, and our blood supply is responsible for carrying our oxygen. So that's how our organs get oxygen and nutrient-rich blood is by our normal, healthy red blood cells being able to travel the way that they should. So you see a ripple effect from sickle cell anemia because of that. Clinically, this is an inherited congenital disease. This is very prevalent in certain geographical locations, and about 8% of African Americans suffer from this. So this is something that is very common in our communities really across the world. There is a technologist, if you have the opportunity to work with him at Rhode Island Hospital, who does a lot of the vascular procedures. He also does transcranial Doppler exams, and he does close work with a clinic who serves young pediatric patients who have sickle cell anemia, and basically they're evaluating that blood supply to these patients' brains to making sure that they can develop properly and making sure that their organs are getting the proper amount of oxygen and blood supply to them. So he has a lot of experience on that. So if you do happen to work with him at Rhode Island Hospital, feel free to ask him questions about this condition. I'm sure he'd be happy to help. These patients are going to be fatigued, have weakness, more prone to infections, joint pain, dizziness. On ultrasound, we're looking specifically at that spleen. We're going to see a variety of appearances depending on the severity of the case per patient. Early stages of sickle cell anemia, we're going to see an enlarged spleen, and of course, anytime our organ is not functioning properly, we're going to start to see atrophy, replacement of those normal healthy tissues with fibrosis or tissue death, which is infarction. So it really is going to depend on that clinical history. Next, we have hemolytic anemia. So this is kind of similar to, it's actually not similar to sickle cell anemia, but they're both types of anemias, right? So hemolytic anemia is basically when we just don't have enough healthy red blood cells. There's not an abnormal shape to the red blood cells like sickle cell anemia. Hemolytic anemia is we just simply don't have enough healthy ones. So this means that we have a decreased lifespan of our erythrocytes, and then also the rate of destruction of our red blood cells is going to be higher than bone marrow can compensate for. So basically our red blood cells are not healthy enough, or we don't have enough healthy ones that, red blood cells, they degenerate very quickly in a normal healthy patient. So these red blood cells are going to die off, and then for these patients with hemolytic anemia, they're not able to produce enough to compensate for that death rate of those red blood cells. So we're basically constantly trying to play catch up in terms of the normal healthy amount of red blood cells in these patients. Another anemia, we have autoimmune hemolytic anemia. So this is when we have that hemolytic anemia that is caused by an autoimmune response or disease. So you can have primary without disease or secondary with disease. So this means, is it primary from an autoimmune response, or is it secondary from a disease? So we're getting a little bit into like that deeper specification of these different types and variations of anemia. So try not to look into it too much. Just know that primary autoimmune hemolytic anemia is from an autoimmune response, and secondary would be from some type of disease. Clinically, it's going to occur in patients who have some type of background history with either an autoimmune response or disease, patients with lymphoma, leukemia, infectious mono, and on ultrasound, we are going to see an enlarged spleen. Next, we have polycythemia vera. This is when we have too many red blood cells. So there's an unknown cause with this that involves all bone marrow elements. So our bone marrow, very primitive structure that's responsible for the production of our red blood cells as well. So that's why we're still kind of looking at the spleen, even though there's something wrong with the bone marrow of the patient. Clinically, weakness and fatigue, vertigo and tinnitus. Vertigo is that instability or, those kind of severe dizzy attacks, and tinnitus is ringing in the ear. Patients are also going to have irritability, erythema, painful extremities. They're going to bruise very easily. On ultrasound, and an enlarged spleen, we could see areas of infarction and potential thrombosis in the spleen. So areas of infarction, the spleen is very prone to areas of infarction, and it's basically when a little neighborhood of organ tissue is not getting the adequate blood supply that they need, so that neighborhood just kind of shuts down. It says, nope, I can't work anymore because I'm not getting adequate blood supply in this region. So on ultrasound, infarcts of the spleen, they kind of look like these hypoechoic triangles in a specific region of the splenic tissue. So they're very common for us to see, especially in patients who are sick or undergoing some type of medical condition. But if you happen to see this finding here, this is classic of a splenic infarction. It's a triangular shaped hypoechoic region. And it's not representing any type of tumor. It's just an area of tissue death. A little pocket of tissue. Next, we have thalassemia. So this is when we don't have enough hemoglobin. So this is going to lead to anemia. This is a precursor for anemia, and it actually causes the destruction of healthy red blood cells. Clinically, it's going to be inherited, so it's a congenital condition or a genetic condition. And on ultrasound, we can see splenomegaly as well. Next, we have some acquired conditions. So moving away from, the systemic conditions, the functional conditions, the blood conditions, and more so to like these isolated splenic dedicated findings. So mononucleosis, this is a viral infection that severely affects the spleen. This is also known as Kissing's disease or kissing disease. Rumor had it back in the day that you got this from kissing somebody or sharing a drink. And that's with any type of virus, right? So teens like to, doctors, old school doctors and parents who are trying to educate teens about mono, there's a lot of like shame that's associated with it, and there's a lot of they're a teenager, so they're probably just kissing a bunch of people, and that's not the case. Like you can get it from a locker room, you can get it from a water fountain in a school. So there shouldn't be like that shame and that stigma that's associated with it. And it can be very embarrassing for teenagers because of that, when it's just completely unnecessary. But it is known as the kissing disease. It's associated with Epstein-Barr virus, which is a very serious condition. You can research that a little bit further if you'd like. Clinically, it's going to be predominant in teens and adolescents. They are going to have tenderness and swelling in the left upper quadrant because their spleen is so enlarged from this infection. They're also going to have swollen lymph nodes, possibly in their neck, axilla, groin, abdomen. We're going to talk about lymph nodes when we get to our lymphatic PowerPoint next. They could also have fever because, again, this is an infection. They could have a sore throat. They could have symptoms of a regular virus, right, of a regular cold, as well as the symptoms of it affecting the spleen. So on ultrasound, we're going to see that very enlarged spleen. Next, we need to be aware of how we can evaluate trauma. So any type of blunt abdominal force trauma is going to be, the most common injury of the abdomen. And the spleen is very sensitive to blunt force trauma. In the emergency room, physicians and providers are slowly being trained in what we call fast ultrasound or fast exams or assessments. And it stands for focused assessment with sonography for trauma. So basically, we're teaching these physicians and these trauma doctors to look for internal bleeding in specific regions of the abdomen, and that's going to indicate how severe that trauma is for that patient. So you need to check your 4 quadrants, your Morrison's pouch, underneath your diaphragm, your subdiaphragm, your liver, and your splenic capsule. So you're looking at the borders or the domes of the liver and the spleen, and then you're also looking at the bladder and the rectal regions. So you're checking your right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant. And you're also checking your Morrison's pouch, your splenic and your liver capsules, the region of your diaphragm on both sides, adjacent to the bladder, adjacent to the rectal region. You are checking in every potential peritoneal and retroperitoneal pocket possible for any type of hemorrhage or blood collection. Clinically, if a patient does have severe trauma to the abdomen, they are going to have decreased levels of hematocrit. Anytime we're talking about an internal bleed or bleeding occurring in an organ, we are seeing decreased levels of hematocrit. And then if it's severe enough, the patient can actually go into shock as well. On ultrasound, we need to be looking in those specific regions, as we just said, and we are looking to evaluate internal bleeding. So we're looking for free fluid, we're looking for anechoic fluid. We're looking to see if there's anything hanging out in any of those regions. So our top picture here, this fluid collection is probably a little bit older than this one. This one's a little bit more anechoic. Again, our settings are not proper for either of these pictures, but this is why we need to be looking at the area around the spleen. Next, we have cysts. So like any cyst located in the body, round, anechoic, posterior enhancement, clear borders, benign finding, asymptomatic, nothing really new here. And moving right along, abscess. Again, we've talked about abscesses in every organ so far, so it's a collection of infected pus. Inflammation is going to be from a directly adjacent organ, so whatever organ it's affecting is going to be considered that type of abscess. So in this case, the splenic abscess. Clinically, patients who are going to be at a higher risk for splenic abscess are going to be patients who are recreational drug users, patients who have endocarditis, which is the inflammation of the cardiac musculature. That is very commonly associated with drug use. So those two kind of go hand in hand. A patient who has decreased immunity, so going back to those physiologic processes, if your spleen can't keep you healthy enough, then you're going to be at a higher risk for these conditions and viruses and infections to occur, and patients of trauma as well. On ultrasound, we're going to see a focal collection of that nasty kind of junky purulent material within the splenic tissue. We could see it have a target or a bullseye appearance. We don't want to confuse that for metastatic spread, right? Mets have a bullseye appearance or a target appearance, but we want to be aware of that patient clinical history. What other information are we given to figure out if a bullseye appearance in the spleen is actually an abscess or metastatic spread? And then we also see enlargement of the spleen as well. So here we have one abscess, and here we have a much larger abscess. Next, we have infarction. So we kind of talked about this already. It's the death of focal splenic tissue. It's going to affect a specific segment of that organ, or a little bit more rarely affecting the entire organ itself. It's the most common cause of focal splenic lesion, so it's very common for us to see this on ultrasound. It's caused by a lack of blood supply to that given region. So there's some type of thrombus or blockage or atrophy of those vessels. Clinically, patients who have pancreatitis or leukemia or lymphatic disorders or sickle cell anemia are going to see these regions of infarction. On ultrasound, we are not going to see splenomegaly with this. If it's an acute infarction, meaning that tissue death just occurred and that tissue just died, we're going to see that hypoechoic wedge or triangle. And as that tissue death has been there for a while, it starts to get a little bit more echogenic. So our top picture would be an acute infarction, and our bottom picture would be a chronic infarction. Next, we have a hemangioma, and you're probably thinking that we just learned about these, but we learned about these in the liver. So this is it's basically the same exact thing. It's the proliferation of those vascular networks. It's a cluster of blood vessels that kind of just hang out. It's the most common benign splenic tumor, not to be confused with what we just said about infarctions. Those are the most common focal finding in the spleen. So this is the most common benign actual tumor. Infarctions are not tumors. Clinically, the patient will be asymptomatic. On ultrasound, this is usually an isolated finding, so we don't really see this in conjunction with anything else going on. We could see a heterogeneous echogenic mass with multiple small hypoechoic areas internally, depending on how big it is. And the heterogeneity is going to be caused by areas of cystic changes or hemorrhage, depending on how old and how big the hemangioma in the spleen is. So this bottom picture, you can see those little areas of hypoechogenicity inside it, right? So it's starting to change, that cystic degeneration. Next, we have a hemangiosarcoma. So this is a little bit different. This is a rare malignant neoplasm arising from vascular cellular tissues of the spleen. So the little cells that line the vessels in the spleen, the endothelial cells, have this malignant proliferation to them, and they create this hemangiosarcoma. Clinically, patients will have weakness, fatigue, loss of appetite, weight loss, and then these tumors, depending on how big they get, can actually rupture and start to bleed out. So again, we're looking for fluid around that spleen. We're looking for hemorrhage around that spleen. On ultrasound, we're going to see this with cystic and solid components, depending on if there is tumor rupture and hemorrhage, and they are going to appear hyperechoic. So they're going to look very similar to a hemangioma, but we need to be able to give a little bit more information about it. Is there surrounding free fluid in the spleen, right, or near the spleen? If there is, chances are it's probably not just a hemangioma. Chances are there's something else going on. Next, we have a hamartoma. This is an abnormal mixture of cells and tissues, mainly of lymphatic or lymphoid tissues. This is a rare and benign tumor. Clinically, the patients will be asymptomatic. They are going to be isoechoic or slightly hyperechoic to the spleen itself, and it can have solid and cystic components. So here you can see this is a pretty big one right here. And again here, showing that this is a solid tumor with active vessels in it. Not to be confused with a hemangioma, right? A hemangioma is very hyperechoic. Hematoma is a mixture of cells, so it's not going to be as hyperechoic as that collection of vessels in a hemangioma, but it is going to have some other similar characteristics. Next, we have lymphangioma. So this is a malformation of our lymphatic channels, which we are going to learn about in our next PowerPoint. It's going to consist of these cystic little pockets and spaces that vary in size. It can involve other organs, but we're mainly going to see it just affecting the spleen. They're rare, benign. Clinically, the patient will be asymptomatic. They could have possible tenderness of the spleen. And then if it is affecting any other organs, they can have some symptoms produced from that as well. On ultrasound, we're going to see a collection of multiple cysts that are usually going to be grouped together. Next, we have lymphoma. So finishing up with lymphoma and then metastatic spread. Lymphoma, the spleen is going to be the most commonly involved organ because the spleen is the largest lymphatic organ. So of course it makes sense that lymphoma is going to mainly affect that spleen. The most common malignant tumor is Hodgkin's and non-Hodgkin's lymphoma. I'm sure everyone has heard of that before. Clinically, a patient who has a history of cancer of some other type can have a higher risk of lymphoma in the future. On ultrasound, it's going to be difficult for us to visualize until it's pretty severe. Once we've kind of reached the later stages, we're going to start to see those lesions occurring in the spleen. The spleen is going to become a little bit enlarged. We also want to be aware if the patient has AIDS in conjunction with lymphoma. If so, we're going to see uniform decreased echogenicity of the spleen itself or focal hypoechoic lesions. So chances are this is something that will be brought to your attention before you scan the patient anyway. That's something that's very easily detected by blood work in the earlier stages. Metastatic disease, so if we have cancer spreading to our spleen, it's going to spread by our blood supply, so hematogenous spread from a common primary organ. The spleen is going to be the 10th most common site of metastatic spread, so we don't see spread to the spleen super often, but it's still enough for us to always make sure that we're giving it a full evaluation. Clinically, we're going to see this in a patient who has a history of cancer. We're going to see multiple or one type of focal lesion, target or halo appearance. There really is such a variety when it comes to the presentation of metastatic spread. And you can see that in these two examples to the side. So right here, we could say that, hey, wait a minute, that actually kind of looks like that abscess picture that we just saw, right? So we need more information. We need to evaluate it further. And even these, we could say, well, wait a minute, are those just hemangiomas, right? What else is going on? Actually, I'm going to erase that picture. I have a glare on my screen right now, and the actual outline is this whole guy. So metastatic spread, we need to be aware of which organ we're looking at, what that ultrasound appearance would commonly look like, what other variations it could take on in that organ. So cancer really is so individually based per patient. So not too much information on this PowerPoint. Maybe some of this will kind of piece together with our lymphatic lecture, so you can hop right on over to that one.